Hello, everyone. Welcome to our August ICARE Genetics Case Conference. I was going to give this over to Amy George, who's going to present our first case before we have our guest expert, Diane Koeller, give her presentation. So Amy, take it away.
So this is a germline EGFR case. So the index patient for me was a 62-year-old woman that was diagnosed with a stage 1 right lower left adenocarcinoma. She was a non-smoker and she had an extensive family history of lung cancer. Her sister had actually just recently died over a very short period of time. And so she really was motivated to talk to somebody about it. There was no one spoke with her about genetics. It was really a patient-driven request, like, hey, mine was caught early, but my sister died. She didn't smoke. I don't smoke. All these people in my family have lung cancer. Like, what's going on? And her oncologist was like, well, you can talk to our genetic counselor. And, I don't normally get indications for lung cancer since we know there's, a significant environmental component. So at first I was like, oh, this is interesting. But when I dug into her case during preparation, I saw that tumor testing had been performed and she did have 2 EGFR mutations, the T790M and the T858R. She had not undergone any sort of treatment because she had stage 1 disease. So we know that these were not acquired mutations due to, resistance of TKI or something like that. So I immediately went from being not very suspicious to she probably has a germline mutation. And so the pre-test counseling appointment was really counseling her on the probability of this being a germline finding actually was significant. And in fact, it was. So this is her family. I wish it could be bigger, but it was hard to fit everybody on there. I call this my COVID project because I spoke with 20 of her relatives during the pandemic, basically during, I think, like the spring, like April, May, June of 2020. So the index patient is the lady with the arrow over here. And this is of course her sister who died very quickly of stage 4 lung cancer. This is her cousin who died of, the gentleman who died. He actually was a patient at our facility. And so I was able to go back and look in his record. And he also had 2 EGFR mutations found on his, I believe they ran a neotype for him because he had stage 4 disease at presentation and he died actually about 2 to 3 months after his diagnosis. So I don't even think no treatment was even initiated due to his swift decline. But, technically had that been noted in 2018, we might have actually known about this mutation, a little bit sooner. My patient was diagnosed with lung cancer in December of 2019. And so I tested 20 of her family members. 11 of them came back with the T790M EGFR mutation. The patient that I have circled whose brother died, we did a low-dose chest CT and she actually had lung cancer on her first low-dose chest CT at 50 years old. She is still living at 54 and has stage 4 disease, but is stable on a maintenance therapy. This other lady who I circled, she also had a low-dose chest CT, which found a incidental kidney neoplasm. So she had a partial nephrectomy and is doing well. No treatment was needed. So all the people who are highlighted yellow are confirmed EGFR T790M positive or obligate carriers of that mutation due to reviewing their tumor testing or knowing that they have the mutation because their child does. So quite a few people who did end up coming back positive. My patient's daughter is actually a physician and has 5 children. So she is doing her screening in the state that she resides in. And so I think that identifying this mutation in the family is actually going to have pretty widespread impact for a lot of people, which is great.
Yeah, great job identifying so many relatives in that family. It was good job with the cascade testing.
So with that, I just wanted to do a brief introduction on Diane. So Diane Koeller is a genetic counselor in the Division of Cancer Genetics and Prevention at Dana-Farber since 2016. She's the lead genetic counselor for the INHERIT study to better understand the role of EGFR in hereditary lung cancer, and co-founder and co-chair of the Gender Inclusive Subcommittee of the National Society of Genetic Counselors Cancer Special Interest Group. The INHERIT study, for those of you who may not be as familiar, was a study that was open a few years ago and stopped recruiting, but they are actively recruiting again. And I say that because in our area of the country, we actually see this more often than many other regions of the country. So there's probably a founder effect. And again, when the Dana-Farber group published in JCO a few years ago, I think that was called out as well. So I would definitely encourage recruitment to their new study. And I'll hand it over to Diane to comment on Amy's case.
Yeah, thank you so much. Thanks for having me. So we're very happy to have our new study open, because there's definitely been a gap for folks like the family Amy just described in terms of getting them resources and trying to better understand what this mutation means. So I think that's a pretty kind of typical case that we often see, where it's often picked up first on tumor testing in people who haven't been treated with any kind of TKI, and then we find out it's germline and kind of go from there. And we often will see a lot of these like incidentally picked up lung cancers on CT scans. We've also seen a lot of like lung nodules, which I'll talk a little bit about. And we sometimes do have trouble getting insurance coverage of the screening, which is part of the reason the studies are so important. So we're really hoping with our new iteration of the INHERIT study to get better screening data to help justify insurance coverage of CT scans for our EGFR positives. So I'll be talking about EGFR and the INHERIT study. This is my disclosure, will not impact anything about my talk today. So just to give a little history lesson on germline EGFR mutations. So germline EGFR T790M was first described in this paper in 2005 in Nature Genetics by Bell et al. And you can see this was a family that was pretty significant in terms of a lot of close relatives with lung cancers and pulmonary nodules identified. Prior to this, it had been established as a somatic acquired resistance mutation, but had never been seen in the germline before. And also, a lot of people just didn't think that hereditary lung cancer was a thing and thought it was all environmental causes of lung cancers. So after that first study, there were several other studies that tried to identify other germline EGFR T790M carriers based on kind of other germline studies looking at things like personal and family history, but they were having limited success, having a really hard time identifying these germline carriers. Then in 2012, Jeff Oxnard found that tumor genotyping was a much more effective screening method compared to relying on personal and family history. So his hypothesis was that if EGFR T790M is a resistance mutation, it really shouldn't be appearing in the tumors prior to treatment. So these germline T790M mutations may be the cause of baseline or treatment-naive somatic T790M mutations. He did a small pilot study of this in 10 unrelated individuals who had treatment-naive EGFR T790M mutations and found that half of those were germline carriers. And 3 out of these 5 had no family history of lung cancer. So if you were trying to find them just based on family history alone, you would have missed them. And this tumor genotyping seemed to be a much more effective screening method. So This brought us to the INHERIT study, which was trying to do a larger scale version of that pilot. So it stands for Investigating Hereditary Risk from T790M. And these are the three goals of the study, were to determine the prevalence of germline EGFR mutations in individuals with somatic T790M in their lung cancer and in relatives of germline carriers, to assess the natural history of lung cancers in germline EGFR carriers, and to estimate the prevalence of lung nodules in these carriers who don't have lung cancer. This is our study schema. So we have three different cohorts that we enrolled through. So cohort 1 was those with tumor genotyping that showed a suspicious EGFR mutation, such as T790M, prior to any treatment. Cohort 2 was relatives of germline EGFR carriers, and cohort 3 were those who had previous outside germline testing results that were positive for a germline EGFR mutation. This study started in 2012, so there were really limited clinical testing options for EGFR at that time. So testing through the study was the easiest way for a lot of people to get testing. It wasn't available at like Invitae or Ambry or anything like that. Participants could be consented either in person or remotely. So we had 3 sites where participants were consented. It was Vanderbilt, Dana-Farber, and Ohio State. But the majority of consents happened remotely because we wanted to make sure we could capture people regardless of location, since this is a rare mutation. Participants had genetic counseling, typically over the phone, and it was like a typical pre-test counseling session describing germline testing for EGFR. They then had testing. It was just targeted EGFR testing, not a panel. They received counseling for the results if they chose to learn their results. So there were a handful of participants who wanted to participate in the study but did not want to learn their results, largely because of how limited our information about EGFR was at the time of this study. They were also counseled about inviting relatives to participate, and we helped get relatives enrolled through cohort 2. And for those who were not diagnosed with a lung cancer, we collected CT imaging and followed them for 2 years to look at lung nodules. So the results of the study that we published last year in JCO, we had 141 participants from 62 apparently unrelated kindreds that were enrolled between December 2012 and April 2018. These participants represented 33 US states, Australia, and Brazil. 131 of the participants elected to complete their EGFR germline testing, and 76 participants from 39 kindreds tested positive for a germline EGFR pathogenic variant. The vast majority of these were T790M. We had one family we picked up with the R776H variant. And ultimately, germline EGFR T790M mutations were found in 52% of our participants who had the mutation in their lung cancer at diagnosis. So really similar to that smaller pilot study, about half of those with pre-treatment somatic T790M were still found to be germline. We analyzed the pedigrees, and within the 39 kindreds, we identified 91 confirmed or obligate EGFR pathogenic variant carriers. 45% of these were unaffected with lung cancer, with a median age of 47 and a range of 29 to 83. 55% were affected with lung cancer, and the median age at diagnosis was 56, but it was quite a wide range of diagnoses from 28 to 83, but the majority were in their 50s, 40s and 50s. 60% had never smoked cigarettes, so we still had a decent portion of folks who had a smoking history, but the majority were never smokers. And 52% of our germline pathogenic variant carriers were diagnosed with lung cancer by age 60. So that's our best penetrance estimate from this cohort, but it's not a large enough group for us to really know how accurate that is. And we do have ascertainment bias here, so that's probably not reflective of the true penetrance. For family history, 35% of probands had a first-degree relative with lung cancer, and 27% had more than one first-degree relative with lung cancer. So the majority did not have a first-degree relative with lung cancer. So this is one of our families with EGFR T790M. This is what I would say is a pretty typical looking family from our cohort. So the proband here is a 70-year-old who was diagnosed with lung cancer at 65, and he was a smoker at the time of his lung cancer diagnosis. His mother and his brother had both passed from lung cancer, and both were never smokers. When I met with him for his pre-test counseling, he was expressing a lot of feelings of guilt and shame surrounding his history of smoking. He kind of felt like he should have known better, and he was really blaming himself for his lung cancer diagnosis. So when he ended up testing positive for the germline EGFR mutation, it actually helped relieve some of that guilt for him, and he didn't feel as much like it was all his fault since it was an inherited risk that he couldn't control. We were also able to test some of his family members, including his children, who then were able to get access to screening with low-dose CTs. His nephew also tested positive, which then confirmed that his brother, who had passed from lung cancer, was an obligate carrier of the mutation. And that was actually also helpful for the family to help kind of solve the mystery of why he had passed from his lung cancer despite never having smoked. So overall, the family felt like it was a positive thing to identify this mutation so they could be proactive and kind of explain what was happening within their family. This is probably a less typical case, but does highlight how different it can look from person to person, even within the same family. So the proband on here is a 46-year-old diagnosed with lung cancer at 46 and had like a social smoking background, nothing too significant. His brother had passed at 21 of lung cancer, and there was no other extended family history of lung cancer. So the younger brother, we don't have a way to confirm whether he carried the EGFR mutation or not, but the proband on here did test positive, as well as his father and his sister, who are both unaffected. And this is a case where the father on here, the 82-year-old, expressed a lot of feelings of guilt. He felt really guilty that he had this mutation and lived to his 80s without ever having known he had it, while two of his sons were affected with lung cancer. So guilt is a really common theme we've seen in counseling these families, unfortunately. In terms of screening, so 15 unaffected EGFR pathogenic variant carriers had CT scans through our study, and we found that 60% had lung nodules, including a 28-year-old who had over 10 lung nodules. We've seen it's pretty common to have multifocal bilateral lung nodules in the folks that we screen. We've referred to it as like a polyposis of the lungs almost, for lack of a better term. One of our participants did also go on to develop lung cancer during our 2-year follow-up period. And we're still really struggling with the ideal screening interval or age to start the screening. It seems clear we should be screening this population, but we don't know what age to start. Do we start in the 20s because we've seen a few cases there, or those outliers? And if somebody has a totally normal scan with no nodules on it, we don't know how frequently we should be following up with more screening. So like was kind of mentioned a little bit earlier, we did notice this kind of clustering in the southeastern US of our EGFR positive probands, because this was not reflective of recruitment. That was much more spread over the country, but of those who tested positive, we saw a clustering within the Southeast US, which made us wonder if there was like a founder effect going on, if there was some explanation for this. So we did a haplotype analysis, and we did find a common shared haplotype. So we did our genome-wide haplotyping of 46 participants with germline EGFR and found that 41% of them had a long shared haplotype region on here. So it's estimated that these 41 folks with the shared haplotype had a shared common ancestor about 250 years ago, and that might explain some of this kind of founder effect that we're seeing in this clustering within the Southeast US. So these are our current germline variants of interest for hereditary lung cancer. So within EGFR, T790M seems to be the clearest cause of hereditary lung cancer risk, as well as R776H, V843I, and V769M have also been seen in suspicious looking families that look similar to T790M. The ERBB2 gene is a really closely related gene to EGFR. So EGFR is also called ERBB1, so they're really similar genes. It's also called the HER2 gene. And there's a particular variant we've seen, the G660D variant, that also appears to be a risk factor for hereditary lung cancer. And this other gene, YAP1, there's a variant R331W. It's been described in Chinese cohorts that have a significant family history of lung cancer. So that's another one that's on our radar, but there are probably others that we're missing that are yet to be discovered. So this is our family that we saw with the R776H variant. This was in our publication. We've seen more folks from this family since that time, but overall it looks really similar to T790M. So you can see the proband on here is a 76-year-old with lung cancer diagnosed at 59, no history of smoking cigarettes. Several close relatives with lung cancers, mostly in never smokers, a lot of people with lung nodules. I believe we've tested about 20 members of this family now who've come back positive. Basically everybody, I think everybody that we have screened for lung cancer has come back with bilateral pulmonary nodules. So it seems to be very common. So ultimately, who should consider genetic counseling or testing? Anybody with a somatic T790M mutation prior to treatment should definitely be offered testing, because we assume about 50% of those are going to end up being germline. If you see any of those other variants from that previous slide in the tumor as well, especially prior to treatment, it makes sense to think about offering germline testing to them, particularly if they're at a higher VAF, if you're doing like circulating tumor DNA testing. A family history of multiple individuals with lung cancers or nodules, particularly in non-smokers. But I think the caveat with that is that family history has not yet been shown to be a great tool for screening people with these germline mutations. Same with young lung cancer patients. While we've seen some young cases, it still hasn't been shown to be a really strong predictor of having a germline mutation. So I put a bit of a question mark on that one. Ultimately, we don't have established testing criteria at this point, so it can still sometimes be challenging to get insurance coverage. So these are our currently available studies. We have 2 different studies. We're doing the same thing on each of them, though. We're just recruiting slightly different populations. So the young lung cancer study, anybody diagnosed with a lung cancer age 45 or younger is eligible to enroll in that. And then we have our new version of the INHERIT study. So for both of these studies, we are offering clinical gene panel testing. So participants are offered an 86 gene panel that is done ad invitae. They also get research whole genome and transcriptome sequencing, but the results from those portions are not returned to the participants. They're purely for research purposes. We'll be looking at things like SNPs and also hopefully doing new gene identification, see if we can identify any novel causes of hereditary lung cancer. We're also doing DNA banking. We do have screening with low-dose CT. At the moment, it is only available in Boston, but we are hoping to try to expand that, to try to reach people across the country and see if we can offer them CT scans. But that is something that's in the works right now. And for the new INHERIT study, it has been expanded beyond just EGFR. So if somebody has a different hereditary lung cancer gene mutation, they might be eligible. We also have criteria based on family history. So if people have a striking family history of lung cancer, they may be eligible to enroll in that as well. So that's all I have for my presentation. I have my contact information up here, and then these are QR codes to links to the Young Lung Study and INHERIT Study websites. So any patients you have who might be interested can just enroll themselves online. They would fill out a questionnaire online, and somebody from our study staff would reach out to them to assess if they're eligible and coordinate blood draws from there. So thank you so much for listening.